day. And I see Tom's still there. I'd lost you for a minute, Tom, but you've appeared again. Morning, everybody. Morning, everybody, and thank you so much for turning out this morning. But I think when we're competing with the weather, we win quite easily this morning. This morning, we're very lucky to have Dr. Tom Brown with us, although he tells us we can drop the doctor as he's now retired. Tom studied medicine and graduated from Edinburgh University, I think, if I'm right, and is a retired consultant psychiatrist. And in the past, he was chair of the Royal College of Psychiatrists in Scotland and was, I think, based at the Western in Glasgow. And Tom's going to talk to us about COVID and well-being in a sort of COVID world. I'm sure that the numbers that are here today are sort of testament to how relevant that is to all of us and our families and friends. So I'm sure we're all looking very much to hear what Tom's going to tell us. So over to you, Tom.
Thank you, Gail, and thanks for inviting me. This is the fourth University of the Third Age meeting that I've addressed. And I think this is by far the biggest turnout. And I think a couple of you have already alluded to the fact that because the meeting's on Zoom and given the weather conditions outside, there are probably more of you here by Zoom than would be face-to-face. So thanks for coming anyway. I'm going to start and try to share my slides. Have you got them? Can you see them?
Yes, we've got them, Tom. Thank you.
Good, good. Interestingly, I said this is the fourth time I've given this talk, and there are probably few talks that I've had to change so much because the situation has evolved so much. I mean, when I first gave the talk, one of the most prominent sources of advice on how to manage COVID-19 was Donald Trump. Mercifully, he's no longer one of the principal advisors, so we needn't discuss him. I put in a couple of caveats. Firstly, I am not a COVID-19 expert. I'm a retired psychiatrist, a retired doctor, and I did indeed work at the Western Infirmary before it was demolished. That's where my office was. And I worked between there and Gartnavel General, not Gartnavel Royal, and we'll just come on to that now. Because although I'm not a COVID-19 expert, there are some reasons why I might have something to say about it. One of my ex-colleague Jacqueline's here as well, and she knows far more than me about, as a public health academic, about these aspects of it. But I don't know if she agrees with me. One of the things about being retired, funnily enough, is that I've got more time to read medical journals than I had when I was working. And I've certainly read the British Medical Journal every week, and while it's not the most high-powered scientific journal, it's very good at summarising what's been said in other better journals, and indeed in pointing you to articles in them. So I've read it weekly since it started. When I worked as a liaison psychiatrist, and liaison psychiatrists are a bit different from other psychiatrists in that my colleagues were not principally other psychiatrists and psychiatric nurses, but were physicians, surgeons, and A&E consultants at the Western and at Gartnavel General. And because Gartnavel General was in my patch, I covered the Brownlee, which was the West of Scotland Regional Infectious Diseases Service. And as I said to a few colleagues at the start of the COVID outbreak, I must have been one of a pretty small number of psychiatrists in the UK who was used to interviewing folk while wearing a gown, a mask and gloves and a helmet, because we sometimes had to do that when people were being isolated in the Brownlee and they required psychiatric assessment. So I certainly had a bit of a feel for that, and a bit of a feel for, more than a bit of a feel for dealing with people with threatening infectious diseases, because that was part of my job. Though as I said, I'm not a COVID expert. I'm going to say a bit, probably very near the end, about what we know about the psychological consequences of COVID-19, because there have been a couple of recent good articles summarising that. I'm going to say a very small amount, again, nearer the end, about how we can look after ourselves and others during this time. And as we emerge from COVID, we're not emerged yet, by the way, as I'm sure you realise, but we are, things have moved on. And I'm going to start by saying a bit about the relationship between physical and mental illness. And this is quite an old slide, but the main message of this slide is that where there is physical illness, and in particular where there is either life-threatening or chronic physical illness, there are high rates of psychiatric comorbidity, like psychiatric disorder coexisting with it. So this is a very old study on rates of depression in people with various physical illnesses, heart attacks, Parkinson's, stroke, rheumatoid, etc., etc. And this is really robust, this finding. If you look at any chronic physical illness or any life-threatening physical illness and look for what happens to people from a psychiatric point of view, lots of people get depression and a few less, but still quite a lot, get anxiety disorders. The other thing I would point out to you about this slide is where the disease has a primary target organ of the brain or the central nervous system, for example, Parkinson's or stroke, the rates of mental disorder accompanying it are even higher. Now, remember this slide and its message, because I'm going to come back to that nearly at the very end. When COVID hit, the Lancet, which is a pretty prestigious medical journal, I'll be saying something about prestige in medical journals in a minute. The Lancet, trying to anticipate what might happen, published a systematic review on what we already knew about the effects of quarantine. Because of course there were lots of infectious diseases in lots of parts of the world which had necessitated quarantining people for periods of time. For example, SARS and loads of other things. The Lancet found that there was a huge literature on the effects of quarantine. They found 3,166 papers, but they said only 24 of them were kind of worth the paper they were written on. And the point to make here is that some medical journals will publish almost anything, and the Lancet imposed a set of criteria that they thought were minimally acceptable for being a decent study of scientific worth. And they found 24 that met their criteria. So most of them didn't, and we'll come back to that as well. So of the ones that were good, and you might say that some of this is blindingly obvious, and one of the other points I'm going to make on this is that if you're a scientist, nothing is blindingly obvious. What you think might happen doesn't always happen, and you have to try and demonstrate whether it does or not. We'll come back to that later, particularly in relation to suicide. So the Lancet found that the big risks of quarantine were how long people were quarantined for, the degree to which they feared infection, things like boredom and frustration, having inadequate supplies of food and other necessary things for daily living, household supplies, being inadequately informed, and suffering financial loss. Now, you may say, and I wouldn't disagree with you, that these things are fairly obvious, but as I said, from a scientific point of view, we must take the standpoint that nothing is obvious. Oh, sorry, there's one off the bottom there, and that was stigma. If you happen to suffer from one of these illnesses, there are varying degrees of stigma that attach, and that too impacts on your psychological vulnerability. There are also a number of fairly obvious societal consequences of COVID that I'll just highlight up front, even although you're well aware of these. Isolation and quarantine, social distancing, the closure of businesses and the consequences of that, the closure of schools, increased hygiene practices, which will impact on some more than others, the pretty drastic impact, particularly in the first year of the pandemic, the impact on normal activities, for example, weddings and funerals, and the threats posed by all of these things. And all of these things increase the risk of mental health problems. There was quite a lot of early medical interest and papers on quarantine during the COVID outbreak, suggesting that things like anxiety, panic attacks, paranoid symptoms, depression, compulsive symptoms, hoarding. You remember the toilet rolls nonsense at the beginning of the pandemic, post-traumatic stress disorder and substance misuse. So these were all being flagged fairly early on from observational medical studies as things that were on the increase, apparently, and I use the word apparently advisedly, as a result of COVID. I just want to make two other points about the importance of psychological factors. Psychological factors are hugely important in the spread of disease. And as I'm sure you've all noticed during this, they're also hugely important in social disorder. So where there is fear, where there is anxiety, where there is paranoia, particularly when you throw substance misuse, alcohol or drugs into the mix, that can be quite socially disruptive. And we've heard all sorts of anecdotes and horror stories during the COVID pandemic about that. There are a couple of other things before I get into the more medical aspects of the talk that I just want to highlight as background. The next one is about the role of the media, and although the role of the media is clearly important in disseminating information, nearly all medical journals that I have read have been pretty critical of the media, especially around exaggerating risks using emotionally charged images and languages. And that, of course, is a particularly problem in social media, which is a lot less regulated. And the media can increase fear, anxiety, or notions of learned helplessness. To quote Fraser from Dad's Army, we're doomed, for example. And social media in particular can enhance divisiveness. And I used Facebook certainly during this, and some of you probably use social media. And I, on more than one occasion, was restrained by my wife because I was getting irritated with what some of my Facebook friends were saying about this. Just a very personal example of how it can enhance divisiveness and cause conflict in a way that's not always helpful. And I think we're all liable to that. This term, social media infodemic, was coined by the president of the WHO, who talked about the social media infodemic and its impact on what was happening around COVID. And he highlighted a number of things. I think you probably remember early on in the pandemic, there was quite a lot of stigmatization of young people for ignoring the advice to wear masks and socially distancing. Pictures of them having parties and stuff like this were, all over social media. Racism was part of that too, particularly, of Chinese people. Xenophobia, to go with that. And he too pointed out that the social media stuff divided people and obviously allowed conspiracy theories and vax denial stuff to pass uncensored or unchallenged. And then, of course, there's the role of government, and I'm going to say very little about this, except to make the terribly obvious point that as individuals, and I don't exclude we who are doctors from this, our take on the whole COVID thing is heavily influenced by our worldview, and that includes our political worldview. I would say that the government provided better information on their websites than they have on TV, though I think the medical guys didn't do too badly, certainly better than a lot of the politicians. But the government clearly has a central role in this in providing support and services to the NHS, which have been variable, but generally got a bit better throughout it. And the government obviously has a role in economic support and in developing policy. And I'm well aware, not least because like you, I've been south of the border a few times during this, that there are quite big differences between Scotland and England and the way this has been approached, not just by the politicians, but by the public at large. The other thing I would like to highlight is that there are a number of psychological factors affecting response, and these impact hugely on acceptance of hygiene practices, hand washings, and other hygiene practices. Social distancing, psychological factors impact hugely on that, and also on willingness to accept vaccines. there are many relevant psychological factors. I'm just going to highlight three. And the first two, if you like, are on a continuum. There are people who inherently have an unrealistic optimism bias. Glass nearly all full people. They underestimate danger, see little need to take precautions. And that might have been a later factor in some. It's not by any means the only reason, but for some in refusing vaccines. And in extremes, these behaviours might pose a societal threat. At the other end of the stream, you've got the other end of the continuum, and we're all somewhere on that continuum. There are people with phenomenally high levels of health anxiety who overestimate danger, make huge demands on services, will excessively self-isolate. I'm going to come back to that at the end as an important factor in how we emerge from this. And these people with high anxiety complain of symptoms all the time, as they probably did before COVID, but COVID's just been another factor in the mix. The other thing I think that is really relevant here is people's ability to tolerate uncertainty. And people who have a high need for predictability will struggle in an environment such as we have been in the last 2 years and will continue to be in. Three things that I want to say something about, because I expect that you'll want me to say something about. I'm going to say something about long COVID, and I've got that in inverted commas deliberately, by the way. I'm going to say something about suicide in COVID, and I'm going to give you a wee update on what the medical literature is saying, as opposed to what I'm saying about the psychological consequences of COVID. Long COVID. Okay, the term long COVID was first used by patients and not by doctors. And I think the most predictable thing we can say about long COVID is that it will be controversial. Think, for example, of the ME, chronic fatigue syndrome, controversy. The Royal Free Disease outbreak, which started when I was a medical student in the 1970s. And this issue is unresolved in the 2020s. And there are many, many similarities between what's happening with long COVID and that. I think there might be one or two differences. And we'll come back to that in a minute or two. A recent comment, because of that, I think, a commentator in the British Medical Journal said of long COVID, the less said, the better. And he didn't mean we shouldn't study it. It wasn't a legitimate area to be studied. He meant that it's way too early to be saying very much at all about long COVID. And the next point I would make is that long-term physical and psychological symptoms can follow any infection, and indeed most physical illnesses. And so that begs the question, is COVID any different? Is it any different to anything else in that regard? Now, it might be. It's too early to say, but it might be. And one of the reasons it might be, and we'll be coming back to this as well, is that from an early stage, it has been known that the SARS-CoV-19 virus has very significant effects in some people on the brain and the central nervous system. So it's got a predilection, if you like, for attacking the brain and the central nervous system. So it might be different, but it might not be. And we shouldn't jump to any conclusions about it. As I say, the most predictable thing we can say about it is that it's going to be controversial. Now, I was surprised that doctors were so slow off the mark here. If you're doing research on long COVID, for example, you can't simply study people who self-identify as having long COVID. Some of them won't even have had COVID, okay? So because there is no diagnostic test for long COVID, nor in my opinion will there be for a long, long time, if ever, because there's no diagnostic test, you have to, if you're going to study this from a scientific point of view, you have to define what you mean. And just in the last few months, a few definitions of long COVID for research purposes have been mooted. That doesn't mean that if you don't meet these, that you've not got some problem post-COVID. But you obviously try if you're trying to do research, you have to try and define who you're researching. You can't just let folk hold their hand up and say, I've got long COVID. Well, you can, but that's a different kind of research. So the research diagnostic criteria that are being suggested, and at least two fairly prestigious groups have agreed on these, are that there has to be evidence that the person's actually had COVID. They have to have had some tests showing they've had COVID. The symptoms that they're now reporting have to have come on within a few months of COVID and have to impact on their physical, social, and mental functioning and interfere with their lives. These criteria are really in an attempt to define a group of people who are clearly quite ill. So they're not just a wee bit off. And they have to have had the symptoms for a minimum of 12 weeks. The definition will usually list a number of symptoms and say they have had so many of these symptoms. And common symptoms that would be included in the list would be things like fatigue, pain, symptoms made worse by exertion, respiratory symptoms, definitely, neurological symptoms, definitely, cognitive symptoms, by which I mean problems in memory and concentration principally, and psychological symptoms like anxiety and depression. I'm just emphasising again, at present, there is no reliable diagnostic test which identifies people as having long COVID. And if you read in the papers that there is, don't believe it. It will almost certainly not be true. It might be something of interest that, that affects a subgroup of patients with COVID. And there have been some recent studies suggesting that, an inherent lung problem in these people. So, but take it with a pinch of salt. It will almost any tests reported in the media at this stage will almost certainly not identify most people who, defined by this definition, have long COVID. I'm going to move on now and say something about what we do know about the psychological and neuropsychological consequences of COVID. And my main source for this is an excellent article in a journal called Brain Behaviour and Immunity. And it was either in October or early November last year. And it was a large review of publications on COVID across the planet that looked at psychological and neuropsychological effects of the COVID. Now, a bit like the Lancet study I quoted to you way back at the beginning, even though this has only been around for 2 years, they found already that there were 1,725 studies in the published scientific literature. And a bit like the Lancet study I mentioned at the beginning, they defined what they felt were the necessary criteria for scientific rigor in these studies, and found that only 66 were of sufficiently good quality for them to consider. And if I tell you that the numbers involved in these 1,725 studies varied from 3 people in one study to 266,586 people in another study, you will get my drift about the variability of the study. I'm not saying bigger is better, but usually a study with 3 people, for example, would be very limited conclusions you could come to from that. The kind of studies that often get reported in the press are, we gave drug X to 25 people with COVID, and 14 of them got better. That study is not useless, but it's limited. It's good at generating hypotheses of what you can then look at in the future in proper research, but it doesn't mean that the drug is going to be particularly helpful, or any other intervention for that matter. So there you go. What did the studies conclude? Of these 66 studies that were reportedly decent, 40 showed high rates of anxiety and depression in people who had COVID. 20 showed high rates of post-traumatic stress disorder. 27 showed significant cognitive deficits, i.e. memory loss, concentration difficulties, what people are identifying as so-called brain fog, and about half of them showed fatigue. Now, I'm going to make another point here, which if it's not terribly obvious, will be after I've said it. Not all of these studies would be looking for all of these things. So, for example, I've said 40 out of 66 studies showed high rates of anxiety and depression. That doesn't mean 26 out of 66 studies showed no anxiety or depression, or low rates of anxiety or depression, they might not have been looking for anxiety and depression. There might have been studies, for example, that were targeting the cognitive defects or post-traumatic stress disorder. So just bear that in mind when you look at that information I've put on that slide. Looking at these 66 studies, 4 big risk factors for psychiatric problems and neuropsychological sequelae were identified. Firstly, the severity of an individual illness, initial illness with COVID. Secondly, the duration of their symptoms, how long they were ill for. Thirdly, being female seemed to make you more vulnerable than male. And fourthly, being in an intensive care unit, especially for post-traumatic stress disorder. Now, I'm just going to chuck in aside here. Post-traumatic stress disorder is a term that has suffered very badly from media exposure, in my view. Most people even when I was working, most people who told me they had PTSD didn't have PTSD. And many people who didn't tell me they had PTSD did have PTSD. PTSD is not just feeling stressed or unable to function after something traumatic happens. It has a very specific meaning. Now, the ICU finding, you would have predicted that. If any of you have been in an ICU as a patient or to work, you will see that, I mean, I was in ICUs every week at the Western and Garton Naval, and they're pretty traumatic places to be in. You know, they're quite scary. And if you remember the stories at the beginning of COVID, which I don't think were exaggerated, life in an intensive care unit, both for the patients suffering from COVID and for the staff, was pretty horrific early on. It was fairly harrowing. So this finding is hardly a surprise. Early findings too identified a couple of possible biological mechanisms of relevant to long COVID. One that, again, you might have seen this phrase in the newspapers, talking about cytokine storms, which is a kind of inflammatory immune response to the infection, which probably, for want of a better medical term, knackered a lot of folks' lungs early on in the thing. And there's also been evidence, and this is not particularly surprising, of an increase in so-called lesions in the abnormalities in the white matter of the brain, which is again, you would kind of predict that. That's not uncommon in people with severe depression, for example. So there are some things emerging already as probably being important in this. Now, just before I go on to what you do, I want to say there's a major limitation to all of this. And think back to my first slide, where I showed you the rates of depression in many, many other physical illnesses. Hardly any of these studies had a comparison group. So they weren't comparing, for example, they weren't comparing people who'd had COVID-19 with people who had diabetes or had a heart attack in the previous year. So we don't know if these apparently high rates of depression, anxiety, PTSD, and COVID are any different to what you would have found in a similar group, age and sex match, with some other physical illness. So these studies are very interesting and quite helpful, but they haven't conclusively established that COVID-19 is any worse than any other chronic or dangerous physical illness in terms of psychological problems. Though they have certainly provided evidence that it's pretty bad. The other thing that, because of the limits of these studies, that it's difficult to do is it's difficult to distinguish the possible directs of COVID-19, for example, on the brain, from the indirect effects of being in a pandemic. So, for example, the effects of lockdown, social isolation, financial loss, etc., etc. You can ask me questions about any of this at the end. Whether I'll have the answers is another matter. Here's an example of what I said early on. If you're a scientist doing research, you never make assumptions about anything, okay? Assumptions are, so a lot of what I've said to you might seem blindingly obvious. If you get this horrible illness, you might get depressed or anxious. Or if you've been in ICU, you might get post-traumatic stress disorder. But you can't assume these things. You've got to to research them properly. And here's the best example of that in relation to COVID, and it's suicide. Almost from week one, there have been articles in the press saying that the COVID pandemic would lead to a suicide pandemic. Just as an aside, as a psychiatrist, I would have said we had a suicide pandemic before COVID. Nearly 1 million people die every year of COVID, of suicide, which is considerably more than die in all the world's conflicts put together. So there's a lot of suicide about anyway. But from the outset, people were predicting COVID would increase suicide rates. Despite what you may have read in the papers or on social media, there's no evidence to support this. However, it's early days yet. As some of you will know, if you want to establish an association, never mind a causal association, between anything and suicide, you need to look at it over a very long period of time. And in suicide terms, 2 years is not a very long period of time. So it's early days yet, and we need to keep monitoring this. And it's not just scientific journals which are saying this. You'd expect them to say it. The Samaritans have said exactly the same thing on their website, whilst correctly warning against complacency with regard to what might happen in relation to suicide. But so far, the majority of studies on suicide and COVID have shown a modest reduction in suicide rates. That doesn't particularly surprise me. There's lots of counterintuitive things about suicide. So, for example, during most conflicts, suicide goes down in the place that the war's happening. Suicide went down during the Troubles in Northern Ireland. So things that you might intuitively think are going to increase it don't always do that. Lewis Appleby, who is the director of the National Centre for Suicide and Homicide at the University of Manchester, in October 2021 said, the short answer is that there's been no effect on suicide. And he, about a year before that, actually predicted this. But he said conclusions should be cautious. In the same article, he highlights that studies from Australia, New Zealand, Canada, Norway, Peru, Sweden, which, if you just look at these countries, they all had very different ways of dealing with COVID-19. But in these studies, studies have reported modest declines or no change. In Japan, they initially reported a fall in suicides, but have gone on to report a rise in young people. In a more recent study in Maryland in the USA, they've reported a fall in suicide in white Caucasians, but a rise in the Black population. And all of this has caused Lewis Appleby to urge us to have a more nuanced approach to the putative links between COVID-19 and suicide. It might not be as simple as an increased or decreased. There may be groups where it would be a bit different. I just wanted to close by, and this is kind of a pain. I'm going to close by going over what you can do to help each other and yourselves. One of the reasons I've had to change this talk since I started, and I think I did the first one about April, May 2020, is that things like vaccination and the emergence of treatments for COVID have been definite game changers. They've definitely, I think, moved us on. So for you, the main drugs that have now been trialled and shown to be probably helpful are some, but not all, antivirals and a group of drugs called monoclonal antibodies. Some of you might be on them for other diseases. They're drugs whose names usually end in Zumab or Imab. And they've definitely changed the way we approach things for reasons that I won't bore you with. And some of you will have had this as well, but for reasons that I won't bore you with, I'm identified as a vulnerable person because of an underlying condition. And as recently as early January, I got a letter from the NHS saying if I contract COVID, I have to phone some hotline. And the reason I have to do that is I may be eligible for one of these emergent pharmaceutical treatments. And I would be very surprised if there aren't other people in this meeting who've had a similar letter. Things that are, there's a kind of medical consensus that these things are helpful. it's by no means as big as it is for vaccination, for example. Testing and isolation, when done properly, have probably also changed things a bit, as have social distancing and masks. So that's a bit more controversial. I think masks is a really interesting one. And I think people divide on masks, not on scientific grounds, but on personal preference and, and political views. I've tried to get some handle on the medical evidence for masks. And I think there's no doubt that at the beginning of COVID, that just seemed like common sense advice. There wasn't a lot of evidence for it. I would have to say in the last 2 years, although it's not overwhelming, the medical evidence for masks has improved with various caveats that I won't bore you with unless you want me to. But that's definitely to such an extent that the journal Nature, which is one of the most prestigious scientific journal in the planet, has now published 2 articles supporting or promoting the use of masks in crowded indoor areas or on public transport. There are yet lots of challenges. Uncertainty about the future, well, yeah, there might be. I think there are some things that are fairly certain about the future too. The need for prolonged lifestyle changes, new normal, that will be debated. Will COVID go away, or will it be a bit like seasonal flu? Most of the medical journals I'm reading recently are saying it will be like seasonal flu, and it will come back, and it will be a bit, people will die of it, not in the numbers that have been happening so far, but just like people die of flu, this will be another infectious disease that people will die of. There's been some early research on the psychological aspects of getting out of the COVID pandemic. And there was an interesting article I read just last week on the importance of psychological flexibility and how an individual responds to and comes out of the pandemic. And the article defines psychological flexibility as, quotes, the ability to recognize and adapt to situational demands in pursuit of personally meaningful longer-term outcomes. And early on, the researchers identified that, and if you remember again one of my earlier slides about psychological vulnerability factors, if you're on the spectrum of people who's ultra cautious and totally withdrawn, that may be a maladaptive coping strategy in terms of things like depression and anxiety. So if you tend to use distraction, disengagement, or substance misuse, for example, you're less likely to emerge from this unscathed than if you take a more measured approach. What can I do to help myself and others? Well, I've ducked out of saying a lot about this, but there are 2 good places I would send you to get advice. And you can have these slides, by the way, so you don't need to scribble this down furiously. The Mental Health Foundation, and I've put its website on there, has got lots of good common sense advice on how you can help yourself and others. And if people do have depression and anxiety, there's a website called Living Life to the Full, developed by one of my ex-colleagues in Glasgow. And I've put the website address on there, which focuses on depression and anxiety using cognitive behavioral therapy, self-help. And quite a lot of it's free, and it's excellent too. And the kind of things that the Mental Health Foundation would emphasize would be sleep hygiene, trying to ensure you get enough sleep, remaining social, talking to people, watching what you eat and drink, still consulting your doctor, don't ignore things you'd normally consult with, rationing media contact, especially social media, and scheduling enjoyable activities. And that's just spelled out a bit more there. Control what can be controlled. Try and find some way to relax and use a technique like mindfulness. Try and keep up, if you're a very negative kind of person, keeping a positive log, keeping a note of what you do and what you've achieved to remind yourself of that can be remarkably helpful. I guess most of the people here are unemployed, but maybe I should make that assumption. But talk to those who make demands on you, whether they're employers or family members or whoever, and try and focus on the here and now rather than dwell unduly on the future. And I've already mentioned the importance of talking. I think that's my last slide. So yes, it is. So I'll open it up for questions and discussion.
Thank you very much for that. If anyone would like a question, if you could put your hand up and then unmute yourself, either put your hand up in the old-fashioned way or use the what Valerie and Rosalind have now, I can see are doing, and then I can spot you easier. So Valerie, would you like to go first?
Tom, that was really, really interesting. Thanks very much indeed. Just to let you know, I'm a now long retired clinical psychologist. Obviously, I've been tracking this with interest as well. Are you aware of the COVID-19 Psychological Research Consortium study at all? It's right, it's worth having a look at. I mean, they've not published the final results yet, though I think there's some kind of early paper out in the system, but not peer-reviewed yet. But it's a group of largely psychologists, but others as well, based in University of Sheffield and Ulster and other universities too, and increasingly internationally. They started in March 2020 doing a prospective population study, tracking the psychological and social consequences of COVID in the general population. So it's a really interesting one to look at. As I can't tell you what they found. They did sort of publish a bit earlier on, and exactly the same as you've said, you know, saying that really the mental health tsunami, in the way that a psychiatrist would define a mental health tsunami, was not actually happening in the earlier stages as the press and social media were predicting. But you know, things may well have developed differently in the general population. Worth having a look at.
Thank you. Thanks, I will.
Rosalind?
Okay. As you said, you're not a vaccine expert, but you're a psychiatrist. I have a 6-year-old grandchild who's got quite a lot of sensory issues. I was chatting to her mum last night about the vaccination of 5 to 11-year-olds, and my daughter is quite anxious about the reaction of her daughter of getting a gag. And I wonder if, kind of on balance, it might be better to decide not to go for it. You know, there's all the issues of, it seems, young people less, although it's quite prevalent in schools. She's kind of trying to balance up the negative psychological effect it would have on her daughter.
Yeah, it's I can't answer that. As I said, I'm not a vaccine expert. I can make a few general comments. Firstly, you know, I'm uneasy about mandatory vaccination of children who are incapable of consenting. You know, I think if things were much more drastic than they were, it would clarify that. If I had a child with any kind of possible neuropsychiatric issues, I think I would be queasy as well. But I can't really answer that. I make a few general comments. One of the worries about anti-vax views is that it may impact negatively on what for decades we've accepted as routine vaccination. So, for example, the WHO published data yesterday showing 180,000 people died of measles last year, and it doesn't take long for measles to get its grip. There's a hospital half a mile up the road from me, and my wife used to work there, and she brought down one day the kind of books from 100 years ago, and the number of people dying of measles are scary. That doesn't answer your question, and I'm not going to answer it, but it's rather a comment generally about possible negative spin-offs from not having vaccination.
I have to say, my daughter's totally not anti-vaccine, you know, and the previous vaccines.
I wouldn't have assumed she was. Yeah.
Not mandatory, so.
Anybody else got a question? Roma? Could you unmute yourself, Roma? Thank you.
I'm obviously a layman or a laywoman, but what concerns me when I think about it is a sort of, not so much depression as a sort of low-level regret. I mean, amongst people our sort of age, in our 80s, we feel that the last 2 years, when we could have been doing so much, maybe still driving, and we won't ever get this back. Grandchildren who have, you know, missed out on 18th birthday celebrations, graduations, things like that. I mean, is this going to be a problem in the future, do you think?
Possibly. I mean, I'd be speculating to say that. You're absolutely right. You can't get them back, but you can make the best of what's left. I think the impact on young people is, again, just like a bit like suicide. It's very early days, and I remember, because I got asked this so often, and it's not my area, I asked a few child and adolescent psychiatrists and a child psychologist that I know about this, and they had various bits of advice, but no easy answers. The only observation I would make, Roma, is that for all this has not been great, it's been considerably better than it would be had we had the Spanish flu, where we couldn't have met by Zoom or even phoned each other. And most parents, as well as professionals that I've spoken to about this, said that they jumped through hoops to keep their children in social contact with other children by whatever means. That's not to say that there would be no loss, but I think certainly in the Western world, we're in a way better position than we would have been a generation or two ago, or still are in some parts of the globe.
Ruth?
Yes, I was interested in your last slide, had a list of things you recommend to do to help someone who has anxiety and difficulty caused by isolation and PSD, post-traumatic stress disorder. And I wondered, is there a way you can get a leaflet that would give some of that advice?
There's loads of ways, Ruth. The Mental Health Foundation website, which is on my slides, you'll get everything that I said will be on there, and there are also free leaflets on the Royal College of Psychiatrists website, and almost certainly, and Valerie might be able to tell me this, almost certainly in the British Psychological Society website as well. So these, if you've got access to the internet, it's not difficult to get good information on them. I've pointed these ones out because they're fairly reliable and credible. Because of course the problem with the internet is you get lots of nonsense on it as well. But I will vouch for these sites that I've told you about.
Thank you. I'll try and get access to that.
If Peter gives you my slides, you should be able to access these websites, no problem.
Thank you. That's very helpful.
Has anyone else got a question? I can't see any more hands, but we're on a few pages. Peter, can you confirm that we can make the slides available?
Well, what will happen today probably is that the YouTube recording of this talk will be made available, which you will see the slides on. To make the slides available, if Tom could have to email them to me, and then we could do that, yes.
I'll do that, Peter. I'll do that the minute we finish.
Thanks.
Tom, I just had a sort of general observation. I mean, obviously the pandemic's had a lot of negative effects on all of our lives, but it has actually had a few positive effects as well, in that I think most of us, you know what, maybe I shouldn't say most of us, but certainly I feel a stronger sense of community and the people round about me than I ever felt before. And you appreciate the smaller things in life in a way we didn't before. And I also just a comment, I noticed today is Random Act of Kindness Day. So maybe we should all resolve to do a random act of kindness today.
No, I think you're right, Gail. This may have brought out the worst in a minority of people, but I think for the majority it's been the opposite. I live in quite a small town. I live in Linlithgow, and right within a month or two of the pandemic starting, we, and I did this not as a psychiatrist, but just as an individual, we set up support, both kind of materially for people to go shopping and help folk who couldn't get out, and also kind of low-level emotional support. And I headed up on that. And within a few days, I had over 6, and we screened them all, and we got disclosure and stuff like that, because we didn't go into it naively. But within a day or two, I had over 60 volunteers to do this, and they did it. So you're right, it has brought people in the community together in many good ways. Yeah.
Anybody else got any more questions? Roma, I see your hands up, but is that from the lap before? It's not a new question.
I know I was just resting my arm. I want my hand wasn't up.
That's
Sorry.
okay.
Hand on the
Okay. Oh, Viv, you need to unmute yourself.
Sorry. I just wondered whether Tom had any comments to make about, he alluded to the difference between the approaches in Scotland and England. I feel it's kind of woven its way into the political panorama in a way that has never been seen before in our health.
Yeah.
And I wondered if you'd any comments about that, and also the personalities, because I must admit I kind of quite liked listening to what people like Jason Leach and Linda Bohm in Edinburgh had to say. I kind of felt that I believed in these people telling the truth. But any comments, Tom, about the personalities?
I don't think it should. I think I think it's self-evident that there are some major differences in approach and in the style of the politicians. I don't want to make political statements. I was making an observation. I've been to England, I think, twice since it started, including once fairly recently. But I volunteered for a charity, and the manager of the charity is English. And she went down to England last week to visit her parents, and she couldn't believe, for example, and I'm using her words, how cavalier people were about masks in shops and public transport in England compared to Scotland. And the only observation I would make is that I suspect that it's top down to some extent.
I actually lived in England at the start of the pandemic and sort of moved back to Scotland 6 or 7 weeks in. And I've had a few trips down since, but the difference between my friends in England, the way their day-to-day living was compared to my day-to-day living up here was quite markedly different. So it is a strange thing. There's a question on the chat, Tom, from A's iPhone, I think. So, and I'm sorry because I don't know who A is, but they've said to ask if allowances are made for the effect of worry about climate change.
I don't understand the question. Oh, you mean the positive effects on climate change because we're not flying around the globe?
Yeah, I'm not sure either.
I'm not sure I understand the question.
I'm not sure if A is still with us. Their signal keeps failing, or if anyone can clarify that at all. No, we might just have to leave that one. Yep, sorry to A that we can't. Yeah, and I think, yeah, sorry to A that we can't answer their question any better. Any more questions? So I think that just leaves it for me to thank you very much, Tom. That was really illuminating today. I think you've given us all a lot to think about. And I've noticed that the sun has come out here in Glasgow. I don't know if it's sunny in Glasgow.
Yes. Yeah, it has here as well, yes.
So we might even all get out to enjoy it.
Typical Scotland.
Thank you so much, Tom, for that presentation today. It was excellent. Thank you. We'll all thank Tom in the usual way. Thank you very much.
My pleasure. Thank you.
And I hope to see as many of you as possible back in the hall in Nova Drive next month. And we've also got our rescheduled Christmas lunch an hour or so after our meeting in the hall. And if you haven't already signed up for that and would like to do so, if you could get in touch with Lynn, that would be great. Okay, thanks very much, everybody. Oh, Viv, I think wants to say, oh no, Viv, do you want to say something? No, she's just waving, I think.
Thank you. Thank you.
Bye.
Thanks very much, everyone. Have a good day.
Bye.
Thank you.